Well, hello, Dr. Christine Ravina. Thank you for joining me on the Healthy Hits. Welcome.
Hi, nice to meet you.
How are you doing today?
I'm pretty good. How are you?
I'm doing all right. It's a little cold and rainy, but
It's pretty cozy. People think it's cozy weather. I don't always appreciate it, but
That's all right.
it's a little cold sometimes. Yeah.
Well, it's good coffee weather, right?
Yeah, for sure.
Absolutely. Well, thank you for joining us. Dr. Ravina is the lovely resident neurosurgery intern at Carillion Clinic, and she is an expert in many things brain related that I am not an expert on, and lovely and a wonderful researcher with a, 40-page CV by now.
I'm working on it.
You're working on it, yeah. It makes me embarrassed to be a PhD myself. But she has graciously agreed to join us today to give us a little background information on subarachnoid hemorrhage and explain it to us, if she will.
But sounds great.
Before we get started, I just want to put out a disclaimer here. We here at the Healthy Hits are doing this for general health information purposes, and that means that all the information is just for health purposes. It should not be considered medical advice or interpreted as promotional endorsements. If you do suffer from any medical ailments, please go see your doctor. Anything to add?
Agreed.
Awesome. All right. So can you tell us what is a subarachnoid hemorrhage?
So kind of in the plain language, it is a bleeding that happens in the brain. It is a specific area in the brain that is kind of between the brain covering and the brain itself, kind of on the surface pretty much. And the most common cause for that bleeding is the rupture of an aneurysm, which is the big part of what we're going to be talking about today.
Okay, so can you explain to me what is an aneurysm?
So aneurysm is kind of like an outpouching in the blood vessel that happens at a spot where the blood vessel wall has become weak. There's multiple risk factors, and I know we're going to talk about a little bit more about that. But the idea is that there's a weak spot in the vessel wall, and sometimes when the blood pressure goes up, for whatever reason, it puts extra stress on that spot, and then that spot just basically leaks. It doesn't really burst like people imagine it bursts like a balloon. It doesn't really happen that way. There's just a little leak that happens, and the varying amount of blood escapes that area, and then it gets deposited around the brain.
Okay, so how do you develop an aneurysm? Is it something you're born with?
Yeah, so there's different theories. The main one being that it develops during your lifetime. There are some that occur in children as well, and very young children. And usually there's some genetic factors or the factors related to how the blood vessels are built, or some components of the wall that might be missing or abnormal. But in the general population, it occurs at some point during lifetime, and most common age being between 35 and 60, about 40 most commonly. And there's a few very common risk factors. Genetics among those, but more so strongly smoking, hypertension, so high blood pressure, smoking. Being a woman, unfortunately, women have higher risk of these.
Oh, no.
That's, we can't do anything about it. This is just how it is. But the good news is about the other risk factors, we can change them. The gender, sex, we cannot change that. And so women are 1.5 times more higher risk of developing brain aneurysm. And so these are three kind of the main factors. And then the genetics is also part of that. So let's say if you have a family member first degree family member who developed it, then you would be considered a higher risk of developing an aneurysm as well.
Okay. Well, I thought I had more things to worry about as I get closer to 40, and now I have to worry about this too. So what are some signs that you might have an aneurysm?
Yeah, so about let's say 20%, 1 in 50 people actually have an aneurysm. They just don't know about it.
Oh.
And they might live for years and years and never know about it. Some aneurysms grow, get bigger, their walls get weaker, and they're more prone to rupturing. So the bigger it is, the higher risk of it leaking or rupturing. And then some people might just live with a small aneurysm for years and nothing ever happens to it. So people just won't know that they have it unless it actually ruptures. And that rupture event is very, very dramatic, catastrophic, a very significant event that there's majority of times that people would notice it, and that it comes usually with a really, really bad headache. And we call that thunderclap headache, the worst headache of their life. That is the headache that once you have it, you know that this is really, I've never had anything like this before.
Oh, wow. So you say a thunderclap headache. Is there a lot of time between maybe experiencing this and being able to get to the hospital?
Right.
Or?
So that's kind of the worrisome part about it, is that 15% of people die even before reaching hospital. It is so bad, and it depends on the amount of blood that has bled around the brain, because it affects the brain significantly, increases the pressure inside the skull. So a lot of people might lose consciousness that moment when it happens. Some people might just have a headache. Some might have nausea, vomiting, just feeling overall sick. They might have some weakness of their arms or legs, depending on where the bleeding is. But really, that when that happens, something dramatic like that, you have to get to the hospital as soon as possible.
Okay. Well, that sounds really bad.
Yeah. So that's why this is such a, I think, important topic to talk about. And the overall mortality from ruptured aneurysms is pretty high. It's up to 50% overall, considering everything, people that die before hospital, and then some that are in the hospital and just end up not doing really well from this. Because there's a lot of things that happen in that immediate period, and even within 2 or 3 weeks after aneurysm rupture. And that's what's unique about aneurysms, is it's not just this initial event that, kills significant amount of people. It's also surviving and kind of getting through this period of time when there's really high risk of stroke, of blood vessels clamping down, on vasospasm is a term for that.
Well, okay. Well, I have many questions, but I guess first is, so once you have the headache, I guess that's really the only sign that something's really going on, I guess.
A lot of times that could be the only sign. Like I said, sometimes person may pass out, or they might be nauseous, or have vomiting too. But a lot of times it's just a headache.
Okay. So I get to the hospital. I call 911. I go to the hospital. What happens next?
So the history, the clinical history, kind of how the symptoms present, and the thunderclap headache, or the worst headache of their life, is one of the textbook symptoms. So that would really alert the doctors. If you or the family member told them, hey, this is what happened, they would be definitely starting with a CAT scan to take a look and see if there's anything major going on, like a hemorrhage or a stroke. Sometimes we can see an older stroke that's been there for a little while. We could see other changes in the brain. But really, the main goal is to rule out the bleeding, which is really, the CAT scan is really the most sensitive thing for.
So can you back up a little bit? What's the difference with the CAT scan versus another kind of scan here? Why the CAT scan?
Yeah, so CAT scan is really the easiest, the cheapest, the fastest type of scan that we can do. If we really have a very high level of suspicion up front, then we might do something that's called CT angiogram, where we put a contrast through the blood vessel, and then we can actually see all the blood vessels really well and make sure that there's nothing abnormal. That's the way that we pick up most of the aneurysms on the scan. But because there's a lot of things that can present this way, including stroke, including, brain tumors, other things unrelated even to nervous system, the first thing that usually is done is the regular CAT scan, and that is available in the majority of the emergency rooms. So that will be the first triage thing that would be done.
Okay, so any basic ED is going to do CAT scan?
Pretty much, yeah. Okay. Whichever has a scanner available, majority of them do.
Okay, and then
Yeah,
they
so
read it.
the bleeding is very obvious on the CAT scan, so that would be picked up pretty much instantly. And then the pattern of that bleeding is what kind of tells us. And then in the conjunction with history, that the doctor is going to gather, understand how this happened, was there trauma involved or not, and then how much blood there is, where it is distributed. The subarachnoid space bleeding it has a very distinct pattern on a CAT scan that we can see, and that tells us, hey, we need to do this other scan to look at the blood vessels and make sure there's not a ruptured aneurysm.
Okay, and the subarachnoid is again that space between the skull and the
pretty much between the skull
the
and there's like the hard brain covering that we call dura, and this is right underneath that, right above the brain, right on the surface. Pretty much, it is around that area where the blood vessels are sitting that are outside the brain, kind of on the base of the brain.
So what does it look like on a CAT scan? Is it just like a blob, a dark gray area, or is
so
it
CAT scan is pretty much a density scan, so it shows substance with different density in different shades of gray or white. Mm-hmm. So the skull, let's say, is going to look really bright white, mm-hmm. and then the brain usually looks gray, and then the bleeding, because the blood clot that forms right after the bleeding happens, it's really dense. So that density is going to show up as a really usually bright area or distribution of brightness on that scan, okay. Which is going to be close to that of the skull because it is very dense right after it happens.
Okay. So bright white smudges are bad.
That's right.
Okay. Avoid the light.
Yes. So that's funny because one of the symptoms is also photophobia, which is that the blood that's in the spinal fluid, it gets distributed in spinal fluid as well, because that's what's around the brain in that space. That's mm-hmm. where it sits. And the irritation from that and from blood spreading around in the spinal fluid mm-hmm. can cause what's called photophobia. So people be afraid of light, not really afraid, but the light's going to be really irritating to them. And so usually when someone comes in the emergency room, you see them kind of laying in a really dark room, sometimes with sunglasses on, because that light really makes that headache even worse.
Huh.
Yeah. There's some parallels there.
Well, there we go.
Yeah.
Okay, so you've got confirmation of a bleeding. You're doing then the CT angio to see mm-hmm. where the pattern
Yeah,
is?
that would be the first step to kind of... Majority of aneurysms really can be ruled out that way because the sensitivity on a CAT scan is pretty high these days. Again, if it is negative, there's still small possibility that there could be aneurysms that we couldn't see because it could be very small and the blood clot might be masking it. So then the next step would be a catheter angiogram where we put kind of like a little tube through the groin or wrist artery, mm-hmm. and that goes up to the brain, and we take pictures, kind of like CAT scan type of pictures with mm-hmm. the dye. So we shoot the dye so we can see blood vessels really, really well, and it kind of removes the bone and the other structures so we can only focus on the blood vessels. So that is the gold standard for workup of blood vessel problems in the brain. The issue, let's say, kind of the specific, I wouldn't call that an issue with this approach, is that it is expensive, it is invasive. So that is usually the next step after mm-hmm. the CT angiogram is done. And that is also an approach through which we can treat it.
Okay, so what I'm imagining some little snake thing up your blood vessels.
Yeah, pretty much that's how it is. So generally talking about brain aneurysms, there's two main ways of treating them. So one is doing an actual craniotomy, which is, opening the skull, removing window of the bone in the skull, going through the folds of the brain, finding where the aneurysm is, and putting a clip on it. Basically, the goal is to prevent blood from going in there so that we would prevent it bleeding again. Because that is the highest risk of complications and mortality is when these bleed again. It's really, really bad prognosis. So we want to prevent that. And then the other way that we're just talking about through the angiogram or endovascular approach, where we use the same tube, we put the dye through it. We can also put small wires and mm-hmm. devices through it that goes where the aneurysm is, and also achieving the same goal. We either put the coils in there, which is like a really thin wire that coils inside the aneurysm sac and prevents the blood from going in there. There's a a different, huge variety of different devices that we can put in there, with the same goal, shutting down that area of the blood vessel that's outpouched, to prevent blood going in there, to prevent it from bleeding again.
Okay. So I'm going to ask some really dumb questions.
Absolutely.
So you said you want to prevent blood from going back in this aneurysm
Mhm.
pouch from bleeding again. So I'm going to assume by you saying that there's a way for that area of the brain to still get blood from other
Oh, absolutely.
places, and that shutting that off isn't going to further hurt that area
Yeah,
of the
so
brain.
there's a whole lot of detail to that. Kind of trying to explain it in the simple terms, there could be a situation where the blood vessel is coming off, like another blood vessel is coming off from the pouch itself, and that kind of complicates things. And usually, a lot of times, we tend to treat those with the open surgical approach, because that allows us to see everything really well, and then we can position the clip in a way that allows the blood to get to that blood vessel still, while we're occluding the majority of the pouch or the area that we think it has bled. There's other approaches through the endovascular technique that allows us to put something like a stent, that coats the walls of the blood vessel and remodels the blood vessel over time. And just the natural demand that the brain has, that it is taking that blood from the little vessel that's coming off of that area, that will kind of naturally keep that vessel open while that abnormal area is going to close down.
That's really cool. So you're also a construction worker.
Absolutely. There is a lot to it, but the idea is we're trying to prevent blood from going in this area that's abnormal and preserve it going to the areas where it's needed, which is literally any blood vessel in the brain is important. So we're trying to do our best to preserve that blood flow.
Very cool. So I'm seeing a lot of little detours in my mind of like
Absolutely.
little stop signs, little roadways this way and that way.
Yeah, it's how I teach students. Sometimes it's a fancy plumbing. That's pretty much what it is. Preserving blood flow, preserving flow through the pipe, fixing the pipe. And, if it's leaky, in this case, it might be leaky. And making sure that the plumbing works.
Well, that's one way to do it.
Yeah.
My plumbing is broken. Okay, so what happens to the blood that's in your head that the bleeding's there?
Yeah.
What do you do with that?
So there isn't really anything we can do about it. So that blood's going to be there. So until the body takes care of it. So it sits in that subarachnoid space, and it breaks down over time into just the chemical components of it. And the cells in the brain and the blood and the CSF are the ones that are taking care of these byproducts over time. Again, the fact that these byproducts are there, they do have some toxic effects on the brain. That's the theory. And on the blood vessels that are surrounding the area. And they affect the reactivity of the blood vessels or how they function. And they can cause what's called the vasospasm. So that means clamping or narrowing of the blood vessels over time because of the exposure of this blood that's all in there in this space. The risk of that is that it can cause stroke. So that's why patients with ruptured aneurysms, they stay in ICU for at least 14 days. And then this kind of overall risk period is up to 21 days. So it is a long, long period of time that these patients spend in the hospital. So we tell them this, that the moment they come in the emergency room, we get over this first bump, which is, getting that aneurysm secured. But the things aren't over there yet. It is more like marathon, not a sprint. So it's going to be a long process of recovery. And we don't know yet how it's going to go. There's ways that we can predict it based on how much the blood is there in the brain, that we can measure it, and we can measure and kind of account for the areas that it has spread to. And then there's scoring systems that tells us the probability of the good or bad outcome and probability of this vasospasm. But again, every person's a little bit different, and definitely everyone needs to be monitored because things can happen suddenly and unexpectedly during this very vulnerable period of within the first 2 weeks after this happens.
Okay, so that sounds horrible.
Yeah, it's It is a long road.
Wow. So
Yeah, so we always try and spend a lot of time with patients and families trying to explain this up front because um, you would think, hey, I'm just getting this procedure done or getting this surgery done and, we'll be out of the woods. It's not really how it works, unfortunately.
okay, so if I were to have, God forbid, have an aneurysm, then I'm getting a scary kind of procedure and get through that okay. Now my body is mopping up the blood,
That's right.
but because my body created the blood and it's having
It's just
these
in the
bad
wrong
effects.
place. That's the
Yeah,
problem.
it's not supposed to be there.
Yeah.
So because it's not supposed to be there, it's gonna wonky up some other things. I might also then have a stroke.
Yes.
And then what do you do if that happens?
So the reason for monitoring closely in ICU is to catch these changes, small changes in the neurologic exam that, the nurses and the doctors can see. Mm-hmm. So let's say suddenly your speech is off or your arm or leg becomes weak suddenly. Mm-hmm. So we can catch that as soon as that happens. There's ways that obviously we know that the most common reason for this is vasospasm. So we're trying to do some medical interventions to open these blood vessels back up so we can bump the blood pressure, we can give more fluids, we can even give pressors to increase the blood pressure so that pressure would kind of push the blood through the narrowed area still to the area of the brain that's lacking it. Mm-hmm. And then in the really bad cases when this doesn't help, then we have to go back to angiographic suite and then do another angiogram and see where this narrowing is, and then we can infuse or directly shoot vasodilators or the drugs that open up the blood vessels directly in that area.
Okay. So how long a time do you have to intervene if you start seeing this reaction?
So the goal is to do it as soon as possible. So that's why we're so very hyper acute about ruptured aneurysm patients. That's why we really keep an eye on them and check on them constantly. The sooner we can start intervention, the better. A lot of times this will go away even just with the blood pressure adjustments, with mm-hmm. the fluid status adjustments. But sometimes we need to do something more in terms of like the endovascular intervention. But yes.
Okay. So what do you tell families to watch out for in their loved one?
Yeah. So, once they're in a hospital, once they're out of the hospital, they're out of this risk period.
Okay.
But then generally, signs of stroke is really what people would be watching out for. If you're seeing someone starting having weakness, drooping of the face, or their speech becomes altered, they're suddenly starting to talk gibberish, or you can't understand what they're speaking. Those would be kind of the main things.
Okay.
That people see.
So what are the long-term effects of having this aneurysm leak or the subarachnoid hemorrhage?
Yeah, so there is quite a long list of those things. As you can imagine, that is a big insult upon the brain. Mm-hmm. It's kind of like being shot with a shotgun. It's a huge amount of stress, and there could be an injury from the blood itself or from the stroke that happens afterwards. Mm-hmm. So a lot of people, up to 60% of the people, will have some sort of long-term consequence. If there is a weakness that develops, and let's say we're unable to open that blood vessel back up, there could be just a consequence of stroke, weakness, and disability that's related to that. And there could be variable degrees of that. Let's say some person might have only some weakness of their hand, some person might have complete weakness of one side of their body. They, might be requiring a lot of support and help and a lot of rehabilitation to get through it.
So this is something that could potentially get better with like PT?
Absolutely. Yeah. It kind of depends on how severe that injury is, mm-hmm. How profound the deficit is. But a lot of times we can get at least some degree of improvement with really, really aggressive physical therapy. So all of our patients are getting that evaluation in the hospital. And then, some are lucky and they get through it. They never get any weakness or any other problems. And then some really need a lot. They need to go to a rehab or sometimes even skilled nursing facility if let's say they require the breathing tube placed because they were really, really sick. And let's say we weren't able to remove it. So they had to have the semi-permanent breathing tube placed through the neck. That's called a tracheostomy. That is also an possibility if things are really not going well and there's a lot of blood and maybe a bigger stroke happened and we're unable to open that blood vessel back up. So there is a pretty wide range of things that can happen.
Well, I'm going to ask a kind of a scarier question then. So you mentioned things really aren't going well. Does that correlate with age? Does that happen maybe with the older you get, the worse
for sure.
it might get?
Definitely. The older we get, the harder it is to kind of bounce back from things like that. That's for sure. And that is going to always be a discussion, between the family, the patient, and the doctors about understanding kind of what the expectations are. Obviously, someone in their 70s or 80s is going to really be really hard for them to recover from a really bad bleed. And let's say if they required the breathing tube placed up front and maybe a tube placed through their brain to drain the spinal fluid because the pressure was really high upon the brain, that situation is really a lot of times really hard to recover from versus, someone who's younger. A lot of times they can recover really well up to the point that they may not have any consequence out of this. So yeah, that's kind of the tricky part about it, is kind of understanding the prognosis, how all these factors play into it, how the clinical course is going to go for each person. It might be different. You might come in just with a headache and might end up having a big stroke. We're going to try and do everything we can to prevent that from happening. But again, there's just so much we can do.
Right. Understandable.
Yeah.
So I'm going to go back a bit and now that I'm aging up a little bit here and apparently a woman that's at a higher risk for this, what can I do to maybe be more aware, or is this something I should get tested for when I get free?
Yeah, so currently there's a lot of studies happening trying to understand kind of the conditions for the screening, what might be worth the effort of screening, because we can be doing CT angiograms on every person. It's just not financially or physically feasible. So we have to come up with a way of stratifying the risk of people and just picking the ones, just like we do with colonoscopy, the ones that are the higher risk for developing problems. Currently, there isn't a very clear guideline on that. One of the more kind of permanent factors is if you had an aneurysm before, you're definitely going to continue having surveillance and magnetic resonance or CT angiograms over time. Or if you have a first degree relative or two that have had an aneurysm, so that means like parents, children, siblings that have had an aneurysm, that's a strong indication and a lot of doctors would be recommending doing just like a screening magnetic resonance angiogram to just make sure there's nothing there. But otherwise, really there isn't any strong guidelines currently for that.
Okay. Is there anything you can do just in general?
Yeah, so the modifiable risk factors, smoking, hypertension, those are the big ones. And those, obviously, quitting smoking and keeping an eye on your blood pressure and treating if it is elevated. Really, that's the best thing that we can do.
Okay. Well, what are some exciting things that might be coming out for new treatments of this?
Yeah, so there's a lot of research currently happening in this cerebrovascular area, which is has to do with the brain and the blood vessels. Trying to understand, there's still a lot of things we don't understand about vasospasm. Now we call that delayed cerebrovascular injury because we found that there's more factors that play into it, not just the fact that the blood vessels clamp down, but there's other factors in the brain and things that in the brain that happen at that time as a reaction, as including an inflammatory reaction to this really, really significant insult that happens. So there's still a lot of work to be done to in order to kind of detect the vasospasm, or like really determine better, more sensitive tests to find it out early, or understand which patients are going to develop it. So, and then have more effective treatments. Currently, there's only one FDA approved medication that everyone gets. But again, with all that, there's a significant portion of patients that develop vasospasm. So there's still a lot to be understood about that.
Well, thank you so much for taking the time to come on and talk with us about this. It's very important and eye-opening.
Yeah, thank you for the invitation, and I'm really excited we had this opportunity to share this a little bit with the public. I think it's important to know. A lot of people come in and they have no idea of what this is. So, and then maybe their family member was affected by this, and it sometimes really helps to have a source of information that's
Absolutely.
Easily accessible.
How common would you say that this is, or how often do you see this?
So it happens. So aneurysms, like I said, 1 in 50 patients. There is about 30,000 ruptures in the United States every year. So you kind of can divide it by states and over time. But I would say it's about 60 patients like that we see every year at Curlian Clinic.
Wow, that seems like
quite significant.
It's
a pretty significant number. Sometimes we don't find aneurysms, but the pattern's really, really convincing. So we might still treat these patients as if they had ruptured aneurysm. But generally, this type of stroke with an aneurysm, this is about the number that we get.
Very good. Again, thank you, and thanks for sharing with us.
Thanks for the invitation.
All right. Bye, guys.
Bye.